The bigger challenge with Pompe is that, one, it's a very slow, progressive, slow onset disease. It takes years for the symptoms to really manifest to the point that the patients may realize there's something going on. And I'm particularly talking about late onset Pompe disease. Infantile Pompe disease is a little bit more catastrophic, so you get picked up earlier, but late onset obviously is a little bit more. So there is an inherent delay in diagnosis. A lot of the symptoms and signs of disease are overlapping with some of the other muscle diseases. So they overlap with muscular dystrophies, especially limb girdle muscular dystrophies. They overlap with polymyositis, if there's such a thing as polymyositis. I'm not a big believer in it. But other metabolic muscle conditions, etc. So it's not unusual for these patients to get misdiagnosed. Now, a lot of them also have back pain because of paraspinal muscle wasting. So they get shunted to orthopedic clinic, and then they get shunted to liver disease clinic because they have elevated transaminases, even though transaminases can come from the muscle. Some of the symptoms are non-specific, so they get a lot of fatigue. They get sleep disordered breathing, etc., which may cause issues there. And generally, there is a lack of awareness amongst general practitioners. And I can venture and say that even amongst the neurologists, and I'm a neurologist, but most general neurologists probably have never seen Pompe. They've never come across a patient with Pompe. So there is generally a lack of awareness for diagnosing Pompe or how to diagnose Pompe in that sense. So I'm going to start with this case. This was one of the first diagnoses of Pompe that I made at Irvine. This is somebody who was in his almost 50s when he first came to see me. He had almost a 20-year history or 30-year history of proximal lower extremity weakness. And his weakness started when he was 25 and had difficulty getting up from the floor and going upstairs. So his lower extremities were the primary issue. And then somewhere around 35 years of age, about 10 years into the muscle weakness, he developed shortness of breath upon exertion. His arms were surprisingly not as affected, which is not unusual in Pompe. Pompe, again, like limb girdle muscular dystrophies, tends to affect the hip flexor muscles way more than shoulder flexor muscles on that. There was no cramps or muscle spasms. And he was thought to have limb girdle muscular dystrophy because his younger brother, who lived in Vegas, had already been diagnosed as limb girdle muscular dystrophy. So the assumption was that he probably has the same disease that his brother has. Now, when I examined him, he had proximal muscle weakness. And by the time I examined him, he did have some upper extremity weakness, primarily in this infraspinatus muscle, so the scapular muscles, which is very early involved in Pompe. But he also had axial muscle atrophy and had bilateral scapular winging as well. His walking was definitely affected, waddling, no sensory symptoms. And the clue to his diagnosis was in his pulmonary function. So in our clinic, we are lucky that we have a full-time respiratory therapist, and we do forced vital capacity in both sitting and supine position every visit. And we were able to detect a 14-point drop or 14% drop in his FVC. Even though his erect FVC, sitting FVC was normal, he dropped by about 14% going supine, suggesting that his diaphragms were affected. And that was the first clue that we had that we are dealing possibly with Pompe. To go along with that, his inspiratory pressure was minus 52, which is quite low as well. So we sent off, back in those days, we could do free enzyme assay. We sent off his blood to Duke. We saw that it was incredibly low. The lower limit of normal was around 4. He was 1.45, so clearly was in the deficiency range. And we did the genetic mutation, and he had 2 mutations. One was the common leaky splice site variant, and the other was a little bit more aggressive mutation. So his diagnosis of late-onset Pompe disease, and now mind you, this is 25 years after he developed symptoms, was confirmed. And based on his diagnosis, his younger brother revisited with his neurologist and was confirmed to have Pompe as well. Currently, this gentleman has been on enzyme replacement therapy since 2006. He was one of the original patients in the Actis gene therapy trial. Unfortunately, he had to go back on the enzyme replacement after 2 years of gene therapy trial, and now developed significant camptocormia. So he has a bent spine when he walks, and also has failure to thrive or unintended weight loss that we are trying to manage at this point. So I'm just going to go over an online survey of people with LOPD that was conducted as part of this session. There were 20 individuals that answered this. 50% of them were based in the US, 50% were based in the UK, and half of them were male, half of them were females, and the mean age was around 47.7 years. Now, 60% of them were involved in patient advocacy, which is great because we need more people sort of advocating and pushing for more reforms. Fairly educated bunch, and fairly sort of even in terms of income and family income as well. Now, the age of onset for the first LOPD symptoms were quite variable. Some of them had it very early, between 0 and 12 years. Some of them had in their teenagers, between 13 and 18. And then a larger number was between 19 and 39. And then some were even later. They weren't diagnosed till their 50s and 60s. So the average age of diagnosis was about 36 and 36.3. But if you look at the right side column, if you look at when the diagnosis was made compared to when the age of onset of symptoms was, there was a considerable delay. So 50% of the patients had a delay of greater than 10 years to establish a diagnosis. And then 20% of patients had a diagnostic delay of over 20 years, which again, in this day and age for a treatable condition is almost unacceptable. If you ask the patient what they think was the reason why they were not diagnosed earlier, and I think a lot of them pointed out that they felt like their primary care physician or healthcare providers were not aware of this rare disease. This is a rare disease. Again, we, at least in academic institutions, we make an effort to educate our trainees, but it's not done in other specialties outside neurology or maybe genetics. So again, a lot of these individuals don't have knowledge of it. 75% of these individuals that were surveyed noted that they were misdiagnosed initially, and 65% said that there is limited availability. And I will tell you about a study that we are doing right now. And a number of these patients are from Missouri. And in rural Missouri, there is a tremendous healthcare shortage. So the physicians are scarce, and the physicians that are there don't have the knowledge, plus they don't have the time. But there's also racial biases as well that we have to deal with. And we're trying to address all of those in a manuscript that I'm writing right now. This delay clearly impacted their daily functioning. It affected their breathing. So by the time they got diagnosed, their breathing was already affected. This could have been prevented, and this could have been delayed. And we don't think about pain in Pompe, but pain in Pompe actually is quite common, and something that needs to be addressed as well. And then, however, despite all of that, when these patients were started on treatment, most of them did not find any additional discomfort with treatment and were satisfied with the treatment overall. So if you look at the pie chart, 50% had no discomfort, 40% had mild discomfort, and 10% had moderate discomfort on that. So as I said, we are in the process of writing our manuscript. This is a multi-center study from 8 centers in the US, and we essentially focused on patients with diagnosed Pompe, and we went back and see how many of them were misdiagnosed initially. So we found for 54 patients, the 3 commonest diagnoses were liver dysfunction, including doing a liver biopsy on them, back problems or back spine problems, and the third was polymyositis, which is a rheumatological condition, and some of these patients were poisoned with immunosuppressive. The mean age of onset for symptoms was about 30 years. The mean age at initial diagnosis, and that may not be the correct diagnosis, was about 38 years. And the mean age at first diagnosis of Pompe was about 42. So luckily, the delay from the initial diagnosis to Pompe diagnosis wasn't bad. But if you see, there was a 12.7-year delay in diagnosis that this person had something. And a lot of factors, as I mentioned, play into it. I think our care in the rural setting is not the same as in the care in the urban setting. There are inherent racial biases, et cetera, that we have to look into as well. And then there are training biases. If somebody comes in with elevated transaminases, the assumption is it's coming from the liver and they get referred to a liver disease specialist. If they come in with weakness and high CK, it's assumed that they have polymyositis and the patient gets referred to a rheumatologist. So again, there are challenges that we have to face at this point. So the take-home message is there is significant delay of diagnosis in late-onset Pompe disease, and it's driven by a diverse range of factors, including awareness amongst medical professionals and symptoms overlapping with other conditions. This creates a significant burden for people living with late-onset Pompe disease, and these delays can be substantial with an average duration of greater than 10 years from symptom onset. So lived experiences of people with LOPD really offer us valuable insights, and hopefully this will can be leveraged into a more improved, a better diagnosis. Thank you.